Thank you again. Thank you very much. This is going to be a very quick overview of things, about something that we don't like to talk about, but it is a reality nonetheless. So what do I do when this happens? I usually wish that it didn't come to work that day. That's the first thing. What is the reality? I mean, I think the reality is that sudden collapse in PCI, thankfully, is uncommon. That less than 1% number that we quote to patients is actually true. And it's always unexpected. And the fact is that no one has seen it all and no one is an expert because these are low frequency, rare events. And so it's important to be aware of that, to be humble, and to take help when you need to. So obviously the basic prevention is key, which means that you take the obvious and right precautions. You don't let the guide jam into the left main, watch your guide pressure like a hawk, don't inject 1,000 milligrams of nitro instead of 100 by mistake, don't inject air, don't forget anticoagulation, check your ACT, don't let the wire go to funny places in the coronary tree and perforate. So those are the obvious, everybody knows that, none of this is new. However, things still happen no matter what. That's the unfortunate truth. And so the way it begins usually is the guy or gal sitting outside will start yelling pressure, which means that the pressure is going down. And so you, as an operator, need to start thinking immediately. And it's reasonable to have some sort of an organized approach in your mind as much as you can be, because reality is that you can't be very organized, but certainly avoid a totally haphazard approach, again, as much as you can in a situation like this. And so the first question you need to ask is this spurious? So, look at the patient, is he awake, is he talking, and if his pressure is going down, then something's wrong. And think about a kinked guide, which might give you a pressure tracing like this. Check and see if your fellow has got his or her thumb on the TUI. That can certainly spuriously lower the pressure. And obviously the action you take is appropriate to that, and that's easy. But reality is that often that's not the case. And the next question you got to ask is this a total arrest situation? The patient is arresting and needs CPR and everything right now. So that's, the ultimate catastrophe. And when that happens, call for help. Don't, especially the older guys, like myself, we should not have the ego that I can handle it all. Call for help. Call, I will often call one of my younger partners to come and join me. And because it always helps to have a second pair of eyes and a second pair of hands looking at things while you're working. There are no egos involved in asking for help. Call a colleague, call the core team, call for a thumper or a CPR device, and inform the surgeons. And in our case, we often will inform the ECMO team that something's gone wrong, stay on standby. And as you're doing that, look at the rhythm. That's one of the first things you want to do. And if it's something like VT or VF, that's actually easy. I actually prefer that. Because if it's VT and VF, I can shock the patient out and usually then look for why it happened. But that's something that's rectifiable. The more concerning thing is when they are in PEA, because that means that things are really, really going bad. And then your action list includes basically to sort of shoot first and think later, because you really have to act now. You act now because the patient is going downhill, and do whatever you need to do to keep the blood pressure up. Defibrillate if it's appropriate. Give intravenous, epi to keep the blood pressure up. Start CPR, good CPR. Get the Lucas device or the thumper on while you start sorting things out in your mind. And these are some of the CPR devices. We have the Lucas in our lab. It is something that all labs, I know it's difficult sometimes, it's costly, all those things, but this is one of those things that a lab should have, because when you need to do CPR and also look at the angiogram, it is very difficult when a human is pushing on the chest. So just keep this in mind. On the other hand, if the patient is sort of not arresting, but is going down fast, so you still have a few moments to think first before you start shooting. Of course, call for help like we discussed in the previous scenario, but in that situation, again, look at the rhythm. That's very important. And if the rhythm is VT, VF, that's easy, shock them out of it. But if they're in sinus or they're heading towards PEA, that's when you have a few seconds, like maybe 30 seconds or 60 seconds to think. And the things that should pop into your mind are these. Is the guide in too deep? You know, because that can make the pressure go down, patient can arrest. Did I inject thrombus? Did I inject air? Did I dissect the vessel and that's why this is happening? Or did I perforate the vessel? And if you think about it, if you look at it, these last few things need you to know what the flow is. And so if you then think about it, these will need an angiogram, but you really can't do an angiogram until you have sorted out the first thing which is the guide in too deep? Because if that is the case and the patient is going downhill and you then take an angiogram, you will dissect the vessel and that'll be the end of it. And so in your action plan, you have a few extra seconds to think. Unless it's VTVF, once the guide issues are settled, you need to know the flow. And you need to know, is there flow or is there no flow? And if there is no flow, why is that happening? And if there is flow, is it down the coronary artery or is it going out of the coronary artery? Those are the things you need to know immediately. And so when you then, oops, sorry about that. And so this is a case, you know, these are on the upper panel, you can see this is actually part of a diagnostic. We were about to do a PCI and the fellow injected air. And look at what happens to the flow. And then this is after we rectified it. Notice that in the first picture, you don't see any air going down, but look at the one on the lower left corner, you see bubbles of air going in. And so when that happens, you know, your action plan has to be very quick. 100% oxygen, that will displace the nitrogen in the air you've injected and help clear it. Give intravenous epi, you've got to keep the blood pressure up. Aggressive flushing, sometimes with saline and blood, both have been described. It has been described to aspirate with a microcatheter to get that air out. And of course, hemodynamic support. And the important thing I want you to understand is that just because you don't see the air, it doesn't mean you didn't inject air. Sometimes you've injected or you've done a test shot or you've just flushed the guide in the catheter and air went down and you never know it. And so if you look at the first example, that was air going down and then it sort of got rectified. Usually air embolism, unless it's massive, is easy to rectify. This is thrombus going down the coronary artery. And you can see filling defects in the artery, the flow is terrible. And when that happens, your action needs to be aspirate the guide, put in a microcatheter, an aspiration catheter and aspirate, intracoronary thrombolytics or intracoronary glycoprotein 2B inhibitor, hemodynamic support, check your ACT. These things should happen quickly and immediately if clot has gone down the artery. Because if enough clot went down the artery to make the patient arrest or nearly arrest, that usually means guide thrombus. And this was a case actually where the operator, this wasn't my case, the operator used Clexane instead of unfractionated heparin. A couple of our operators like to use that, and there was clot in the guide, and that went down, and this patient barely made it alive. I want to also point out that no reflow can also look quite the same. That's the same picture, and this could also be no reflow. The difference is that with no reflow, it's usually not all the vessels. It'll be one vessel that you were working on, hopefully not all of the vessels. And your action plan is a little bit different in the sense that we don't know if aspiration or 2B3A inhibitors help in this situation. We often give it, but it's more placebo than reality. We often aspirate, but the clot's already gone down, so there's nothing left to aspirate. But what does work is hemodynamic support, check your ACT, and give distal, as we discussed a few minutes ago, distal adenosine, distal epinephrine, get the flow going. Of course, a blocked pipe is bad, but a leaking pipe is even worse. And that's one of the other things when I say you need to know the flow, you need to know where dye is going. And so if it's not going, that's one thing. But if it's going, but it's coming out, then that's bad news. And I want to just show this case. This is very similar to the case that Ali showed maybe an hour ago. This is a straightforward RCA. You can see on the left. And after putting in a stent, that happened. That is worse than the perf you had. This is an LS3 perforation. As soon as I saw that, I didn't feel good. I called for help. I called for everybody because I knew this patient was going to arrest pretty soon. What I did immediately is what Ali did, inflated the balloon and blocked the artery. Next thing we did, we went ping pong, got femoral access, put in a guide, and then went ahead and put in a covered stent. By this time then, with the gradual things going on, the patient's pressure tanks, we do a pericardiocentesis, and then, finally this patient did okay. And this was about 8 years ago, and he's still alive. But the thing is that you had to do things in sequence and quickly to get it going. And again, much better than me, Ali showed exactly how you should do, and that was a brilliant case. So just to recap, you've got somebody going downhill, you call for help, you look at the rhythm, it's not VT, it's sinus rhythm, he's heading towards PEA, and you've excluded all these other things. And I didn't bring up dissection, but the dissection is obvious. When that happens, you need to stent. But sometimes none of these are going on, and so then there are no flow issues. The flow down the artery is good, and the flow is not going out of the artery, so there's no perforation. And that's when I want you all, especially the younger guys in the audience, to think of the odd things that over the years I've seen happen. And if they're not in your mind, you don't think of them until sometimes it's too late. And those are some of those things are over here. Think in terms that, is the patient bleeding? So if you're doing especially femoral access, lift the drapes and see, is the groin swelling up or blowing up? Because sometimes they could be bleeding and you won't know about it. Look at the guide. Is there acute aortic insufficiency? And this is something that very few people think of, but sometimes when you're working with guides like the Amplatz and it's dipping into the aortic valve, it can cause acute aortic regurg, and that can cause hemodynamic collapse. And I'll show you where that report came from. It is known, it is awfully rare, but it's something you do need to think about when nothing else seems to be fitting. Look at the aorta. Is there an aortic dissection? Usually you'll see staining and you'll know something is going on, but sometimes the staining can be very mild, but the aorta is actively dissecting in front of you and the patient is going downhill. Think of that. Also, look at the patient. Is he flushed? Is he red? Is he got hives? Think of anaphylaxis. It is rare, but it can happen, and the treatment, of course, is very different. And finally, look at the history, or at least ask somebody to look at the history. Could this be an adrenal crisis? When the patient is hypotensive and going down and nothing else seems to be fitting, everything else is good, think of adrenal insufficiency. And I had a patient 10 years ago and then one 7 years ago where it turned out that they were on steroids and nobody knew about it, and the stress of the PCI put them into an adrenal crisis, and only when we gave them IV Solumedrol, etc., they actually got better. And this is that report that was published in '97, where you can see this is a printed report. That's an Amplatz catheter engaging the right, and this catheter has side holes, and you can see that the aorta is fine. There's no dye going in the LV, and now this catheter is sort of abutting against the aortic valve, and you can see wide open aortic regurg. And then when they did an aortic, they pulled the catheter back, and that's it. All you have to do is pull the guide catheter back and everything gets solved. So it's very easy to fix. And they did an aortogram and everything was okay. Just think of it, because if you don't think of it, I had this happen to me maybe 5 years ago, and it took me a while to figure it out. So it does happen, although it's rare. And of course, during the course of the crash, be the leader, listen to everyone, listen to your nursing staff, listen to your technical staff, listen to your fellows, listen to your colleagues, because everybody will have very useful input. And it takes a heroic team to get a patient through. And as Ali very rightly said, the objective is not you saving the day, it's the team to save the patient and get him through this. The key is to have a sequence of thoughts in mind and not be completely haphazard, have some order, although obviously things get chaotic in the lab. And for most cases, you will be able to think and then act. But in the ultimate collapse or catastrophe, you need to act first and then think later. Ladies and gentlemen, thank you very much for your attention.